My name is Christopher Liu. I work in Brighton, England, and I'm an advocate for safe, immediately sequential bilateral cataract surgery. I have no financial interest to declare. The mood is changing from taboo to mainstream, and with NICE guidance in the UK, we are asked to consider bilateral same-day surgery for suitable adults with bilateral visually symptomatic cataracts. And with the pandemic, to reduce person-to-person spread, it is logical that we should reduce hospital visits. Bilateral same-day cataract surgery is not practiced very much, but the prevalence is increasing and the patient acceptance has gone up to 45% according to a recent study done at St Thomas's Hospital in London. The advantages of ICBCs are that everything is done in one go, so one referral, one consultation, one preoperative assessment, one visit for surgery, no period of binocular imbalance, one visit to optometrist for sight test, and one new pair of glasses. And health economics are such that it is more efficient in that more eyes can be done in the same operating time, although fewer patients will be operated on. There is reduced travel and time off for patients and carers and a reduced carbon footprint. The disadvantages of ICBCs are taking a risk with both eyes at the same sitting, double discomfort during surgery and the post-operative recovery period. Some patients may not be able to manage putting post-operative drops in both eyes, and there is potential financial loss to surgeon and institution in that bilateral cataract surgery on the same day is usually not remunerated as double that of unilateral cataract surgery. Who can offer ICBCs? Well, the surgeon needs to have a good understanding of ICBCs, and the surgeon, the team and hospital have all got to have good track records for patient safety and infection rates. With the team, it needs to be cohesive, and there should be no new team members without proper induction. As mentioned, adults with bilaterally visually symptomatic cataracts can be considered for ICBCs, and for the novice bilateral cataract surgeon, they should stick to low-risk eyes and low-risk patients. The operation should not be expected to be prolonged. If the patient needs a general anesthetic, especially a high-risk general anesthetic, that may sway towards ICBCs so as to avoid a second high-risk general anesthetic. There is a 3-step safety protocol: suitable case selection, option not to proceed with the second eye if the first eye has not gone exceedingly well, and treating each eye as independent operation with rescrubbing, regowning, regloving, and use of devices, solutions, medicines, and instruments which enter the eye from different manufacturers or bear different batch numbers. And also, the two phaco probes should have gone through different sterilization cycles, was preferably held back from the previous week and therefore of proven sterility. Excluding high-risk eyes, eyes with a high risk of infection, such as untreated blepharitis, blocked tear ducts, diabetes, immunosuppression, or iodine allergy, where there's a risk of corneal decompensation, glaucoma, retinal detachment, risk of biometry error, risk of intraocular inflammation, and any lenticular abnormalities such as pseudoexfoliation, subluxation, phacodonesis, and previous trauma. So here are some images of these not so simple cataracts. The option not to proceed with the second eye, we know that the risk of endophthalmitis is increased by vitreous loss in the length of the operation, risk of cystoid macular edema and retinal detachment increased by vitreous loss. So therefore, if there's been complications such as PC tears, sonal adhesions, long operation or high phaco energy, we can say, well, we're not going to do the second eye. Therefore, it is immediately sequential and not bilateral simultaneous. It is one after the other, and there's the option not to proceed with the second eye. My protocol is usually operates on the denser cataract with a long, clear temporal corneal incision and a low threshold to suture if necessary. The second eye gets a scleral tunnel for added physical strength and lower risk of endophthalmitis. And also the second eye gets the subtenons to reduce discomfort for the second eye syndrome. And they are asked to wear the shield day and night for physical protection, and also not to wear a face mask in the first week for fear of misdirected breath from the oral pharynx. The ethical considerations are fully considered in this article published in the Journal of Medical Ethics, which condenses a workshop lasting 3.5 hours into the article. Basically, the patient should be given a choice even if the surgeon does not offer ICBCs. It should still be discussed if the patient is suitable, and they should be referred to a colleague who offers ICBCs if the patient wishes to proceed. Other purported issues producing two queues in that patients still waiting for their first eye to be done is disadvantaged by patients who gets both eyes done at the same sitting. This is true for the first few months, but because ICBCs is more efficient, then after the initial hump, the waiting time will actually be shorter. Regarding training, trainees can operate on the second eye, and if they are competent and proficient, they can actually operate on both eyes under supervision. There are extra preparations for nurses in that they have to prepare left eye trolley and right eye trolley, but manufacturers are already planning to put together right and left eye packs, which will make theatre or OR nurses' life easier. The uncertainties lie with we do not really know how big a risk there is for bilateral endophthalmitis, but I think it will be exceedingly rare according to Dr. Steve Arshinoff's publications. I generally quote a risk of 1 in 200,000. For cystoid macular edema, we know that not all cases resolve fully, so that remains a risk. Bioptry and refractive surprise, not so much a problem with partial coherence laser interferometry and a modern formulae. Here's a book that we put together, so a little plug, and I wish to thank you for your kind attention and leave you with my email addresses to contact me for discussion as you wish. Thank you again.